This is the video of laparoscopic Heller's cardiomyotomy in dilated tortuous esophagus. This is the CT of the patient. You can see the dilated esophagus with content is there and it is tortuous on the right side. More of right side tortuous. That was confirmed with barium swallow, and even 5 minutes delayed film shows stasis of contrast in the esophagus. So, manometry shows normal IRP, but there is absent contractility is absent. There is no contraction manometry wise. But the dilated tortuous, if he straighten the esophagus and then do myotomy, little long myotomy, that will be helpful. Is no need for esophagectomy in this kind of patient, and most of the patient will be benefited with the long myotomy. Only thing, you have to straighten the esophagus before myotomy. So, as usual, 5 ports and is described in first 2 videos. Liver is being retracted with the subxiphoid 5 mm port. Stomach is retract the stomach with the left lateral port, and both subcostal port is working port. Camera is in the supraumbilical region. So, initially gastrohepatic momentum is being divided. This patient does not have any accessory artery to the liver. So, I am dividing the gastrohepatic momentum and reaching the crest diaphragm, and this is the peritoneal attachment alone I am removing. I am not going for a phrenoesophageal now, only the peritoneal attachment on the crest. I am going laterally, there is a bad area of stomach. So, now I am coming medial. So, all the dissection is same, I am not changing in any of the cases, and initially the fat coverage of the right crest will be taken out and try to do retroesophageal dissection, or you can enter into the hiatus, and you have to be careful about the vagus nerve. Even here also you can see the vagus nerve is very close. You can see the vagus nerve, that post-vagus trunk, that is the post-vagus trunk. So, I am dividing the phrenoesophageal now. So, that is the phrenoesophageal membrane. So, what I am dividing is the phrenoesophageal. I am protecting the right vagus, left vagus, that is the anterior vagus, with my left hand force instrument. You can see that is the vagus now. I am protecting, I am dividing the phrenoesophageal membrane from the crest attachment. So, that is the phrenoesophageal membrane. Here itself you can appreciate the dilated esophagus. Compare with the previous case, this is much dilated, that is a bare area of stomach is being dissected. So, we have to be careful about the vagus now. So, in dilated esophagus, it will be away from the esophagus, it is not close to the esophagus. So, injury to the vagus is common in this type of cases. So, I am doing a retroesophageal dissection, and I am using harmonic HD. That is a new version. New version means it is long time is there. Compared with the regular harmonic, here there is the instrument comes with the tube and other thing with the directly you can connect the generator, and then the life of the instrument is 10 hours. So, each time you can use 5 minutes, 10 minutes. So, many number of cases you can use it, but it is very good coagulate effect is there compared with the regular harmonic, and the ergonomically designed handle, long tip. So, it is a good for nodal dissection in a malignant surgery. So, now I am dissecting left side of the esophagus. You can see I open my instrument, I am retracting the esophagus, that is the pleura is separated. So, now I am coming anterior. So, now you can see the left side is so much space is there, because the esophagus is turned to right side, dilated portion is more on right, that is the vagus nerve. I see the vagus nerve. Always any tubular structure small, even it looks like artery only, but even though I am checking the vagus and then I am dividing the tubular structure, that practice would be there, so that accidental injury of vagus will be prevented. Now, I am coming on the right side dissection. I have to straighten the esophagus, then only the postoperative dysphagia will be reduced. After myotomy, dysphagia will be reduced, but straightening of the esophagus is mandatory in a tortuous, dilated tortuous esophagus. So, the mediastinal dissection I am doing to straighten the esophagus. Now, you can see the pleura is being separated on medial side, right side, and then posterior. Both I am simultaneously I am doing. Thinned out pleura. I'm trying to avoid the pleural injury. Even if the pleural injury happen, it is no harm. If you can come out in the no, if it is there is no hypoxia and all. If it is any changes in anesthesia side, then you can put ICD. Otherwise, is no need for ICD in all cases. So I dissected on left side. Again, I am coming on right side because the traction is given in the stomach. It is not on the esophagus, so it is slipping. So what I decided, okay, because after with the stomach, no, I cannot do medial dissection. So I have to do with the esophageal traction, so that you can see the tape in umbilic tape, cotton tape is tied. It is not very tight around the esophagus, OG junction as in fundoplication case. So this is just tying that, and gauze piece is required to clean that blood, and I am going to separate the pleura on the right side of the esophagus and the posterior, so that once the pleural attachment is gone, the esophagus becomes straight because I am giving traction. So it will be straight. So we have to go. I have to see the esophagus on the center, no, middle. Up to that level, I go, and so now you can see it is getting straightened now. Because of these adhesions and dilated, the contractility is of absent contractility is there, but that will regain, because if it is a more than 6 centimeter on horizontal diameter on barium swallow, then I am advising the for a esophagectomy, Ivurley's esophagectomy. Some patients transhiatal McEwen's esophagectomy. So otherwise, my extended myotomy, straighten the esophagus, and extended myotomy is the first line of treatment in these type of cases. Less than 6 centimeter diameter of the esophagus with the dilated, even the tortuosity is there, you can able to straight by doing the mediastinal dissection and do the long myotomy. So I am doing gradually medial, posterior, now I am doing anterior side. Now on the left side. Long standing, it's, you can see the fibers are thick. It looks thin, but it is strong fibers. So now it's straight. So I'm going for OG junction, pad of fat, and antervagus mobilization. So I start from the lesser curvature. I take out all the fatty layer, and then the covering, peritoneal covering of the stomach and esophagus. Now you can see the bad area muscle is seen very badly. So the fat is being taken out. So these are all steps described in the previous cases, same way, and you can see the esophageal longitudinal muscle. So that is very important. Otherwise, if you keep this layer, you have to use more force to divide this layer. You cannot separate easily, and that's why this is considered very important. During the vagal mobilization, the peritoneal tissue covering on the esophageal wall will be divided, and then the longitudinal muscle is exposed. So hereafter I separate the longitudinal muscle and identify the circular muscle, and then I divide the circular muscle. So, the vagus is mobilized. Usually, it's crossed the esophagus from left to right in the lower esophagus. Now, I am going for a gastric fundus mobilization, fundus of stomach mobilization, and only one or two vessels of short gastric will be divided, and we are doing a 2-pay. Usually, I do 2-pay fundoplication on after Heller's cardiomyotomy. We believe that 2-pay posterior 180 is giving more reflex control than anterior 180. That's why we are doing a 2-pay fundoplication. So, I am holding the post wall of stomach now, and that is the vessel I am dividing. Again shift the instrument, and these are all posterior gastric branches, branches from gastric and short gastric. Once the exposure is good and your instrument is parallel perpendicular to the vessel, then you can divide. If exposure is not good, don't divide the vessel. If it is bleeds, then difficult to control. So, these are all close to splenic artery, very difficult to control. So, that is why you retract the stomach, exposure is nice, then you can operate. So, I am checking the stomach fundus mobilization, whether it is reaching this side or not. It is reaching, suicide maneuver is being done. So, even if you leave, it is staying there. So, it is good. So, now again I am going for the mediastinal side. So, posterior also, both right side, posterior, everything, all left side, everything is mobilized. Otherwise, it will not straight. So, it is a very wide hiatus. I am closing the hiatus, crura, both right pillar and left pillar of right crest. I am suturing it. One suture or maximum 2 suture is enough. It is not that reflex fundoplication. I am not going to suture completely. Just I do only one suture. So, now this is the time for myotomy. So, I straighten the esophagus. I start around 1 to 2 centimeter above the OG junction. I am separating the longitudinal muscle. This case is done in a long time. It is in the year of 20. So, almost 6 years before it was done. So, this case I used the scissor. So, nowadays I am using a Maryland, 2 Maryland forceps to divide the circular fiber. Second video I showed the newer technique. I just take out the separate the longitudinal muscle around 4-5 centimeter, and then I started dividing the circular muscle. But here I immediately I am dividing both circular and longitudinal together with the scissor. That scissor is lower blade is like a regular monopolar straight scissor. The lower blade is insulated all around, both below, side and tip, everywhere it is insulated, so that the current is not going to the posterior, the mucosa, current is not going to the mucosa. And I have to go little bit on submucosa. Now you can see I am venting into the submucosally. Once it is in submucosa, it is like a poem plane. Now you can go, you can introduce your blunt instrument in the submucosal plane around 5-6 centimeter continuously. So, I am dissecting with the scissor itself, and then I am dividing the tissue. I have to go around the minimum 10 centimeter on the dilated portion. After straighten the esophagus, minimum 10 centimeter on dilated, 3 centimeter on this side. So, the esophagus almost 8-9 centimeter, OG junction 2 centimeter. So, it is a dilated esophagus 10 centimeter, 9 to 10 centimeter, 2 centimeter on OG junction, again 2 centimeter on gastric fundus, gastric side. So, it is on around almost 13 centimeter to 14 centimeter length of myotomy I am going to make. So, muscles are very much thicker. You can see the thick muscle. This tip is very blunt tip, so I can introduce, I can cut. Once you leave the traction, this will go into the mediastinum. So, I am dissecting some more tissues, separating the muscle fiber, circular muscle, longitudinal muscle from the mucosa, and then I am dividing now. So, almost 10 centimeter length of myotomy already I made on the esophagus. So, I am separating the muscle. So, anterior 180, anterior side of the. So, now I am coming on OG junction and gastric side. So, this will be around 3 to 4 centimeter. So, almost 13 to 14 centimeter by myotomy I am making it. Even some of my cases are type 3 achalasia manometry wise, and those patients not dilated, the esophagus will not be there, but it is so much contraction of esophagus. So, I used to do myotomy 15 centimeter to 20 centimeter length. Gastric side is only on 2 or maximum 3. Esophageal side is around 15 centimeter. It is possible. I retract the left pillar of right crest with the sling fibers, with the suture material, and then hiatal mediastinal exposure will be good. I can go up to around 13-14 centimeter. It's very easy only. Even type 3 Heller's type 3 achalasia cardia also, we do Heller's with the long myotomy. Usually people will tell type 3 means poem is the indication they can do long myotomy, but laparoscopically I am doing it. It is possible. Only thing we need to have some 2-3 steps extra we have to do that for a myotomy. So, now almost 2.2 to 2.5 centimeter length of gastric side myotomy is being done. So, each fiber you are seeing with the 4K monitor, 4K camera, and then you are separating the muscle. And I will try to show in a future video the fluorescence ICG options. I inject the ICG before myotomy on the Ryle's tube. I keep the Ryle's tube in the middle of the esophagus and then inject the ICG. Then when I start the myotomy, the mucosa will seen in a green color. So, the muscle will be pink color, mucosa is green color. So, I am just measuring. So, the tip of the instrument to Karlstorff's K is 5 centimeter, it is almost 14 to 15 centimeters. So, Ryle's tube is being passed now. Ryle's tube is pushed into the esophagus. So, air is being injected. I do not do endoscopic examination, apagioscopy during achalasia, just insufflate the air and then put a saline, insufflate the air. If you do air leak test, that is enough. So, now you can see the air is coming. See, I am just pressing it inside, so there is no leak. In redo Heller or redo Fundo, then I go for a perioperative endoscopy, apagioscopy. So, this patient done in COVID time, imagine no, now it is almost 5 to 6 years now that it is asymptomatic patient. So, that is the advantage of this type of long myotomy in a dilated esophagus. We have to straighten and then you get to do long myotomy. So, I could see the postvagal trunk. So, these fibers I am taking it out, and because I am going to take the gastric fundus, post wall of fundus on the right side of the patient, that is the right side of the esophagus, so that this fiber will not disturb when I taking the fundus. So, this is the gastric fundus. Now, I am holding the post wall. So, this post wall of fundus is coming on the between the vagus and the esophagus. So, that is the anterior wall. So, I have some, I want to mobilize some more. So, I am dissecting here From the basically from the pancreas, upper border and the splenic artery, the tissues are being released. So that some more free movement of the fundus will be there. So that's why before myotomy you have to do all those things. So I checked before myotomy, that time it looks adequate. So I take the gastric post wall of fundus. See, 3 stitch I have to take 3 centimeter length, 1 centimeter distance, 3 stitch I am going to take fundus to the, that is a post wall of fundus to the divided muscle on the right side of the esophagus. So this is the ethibond suture. You can see I am taking posterior wall of the fundus, not anterior wall. So this is a non-absorbable polyester suture and small needle, so easy to handle, and tissue thread memory is also very less, so handling is easier. So I am taking another suture, second suture on the post wall of fundus to the divided muscle on the esophagus. Again, this is the third one. So each 1 centimeter distance, so 3 centimeter length of fundoplication is done. So now it is, I am coming to the left side. This is the anterior wall of the fundus. This is the anterior wall. This is the divided muscle on the left side of the esophagus. Again, 3 suture to be done. So again, anterior wall to the divided muscle. So this suture will keep the fundus and the esophageal wall together, and also it will prevent the rejoining of the muscle. It will keep the muscle away, divided edge of the muscle away. So the rejoining of the muscle will not be there. So the patient will not have symptomatic for long time. Will be symptom free for long time. So this is the third suture. So 3 suture on the right side of the divided muscle of esophagus, 3 suture on the left side of the esophagus. So this completes the procedure. Now I am fixing, so already fundus is fixed to 6 suture with the esophagus, and this is the transmigration suture. The fundus of the stomach, post wall of fundus of stomach is fixed to the right crest of the esophagus. So this completes the procedure, laparoscopic Heller's cardiomyotomy in dilated tortuous esophagus with the long myotomy. You can see now it is going inside the mediastinum. It is almost 15 centimeter myotomy I made for this patient. Until today, almost 7 years now, 6 years is completed, the 7th year, operated in 2020, but no, there is no problem for the patient. Thank you so much.